So welcome, really nice to have you guys here. I'm very happy to be hosting the Mentor AKT Strategy webinar. There may be a few latecomers, but we'll let some people in. But thank you so much for your prompt arrival this evening. So I'm Nigel Giam, and I'm the lead GP Training Program Director for the St Mary's Scheme. So I've been doing that really since 2007 for some time. I'm also an ARCP chair for HE London, as well as an accredited AKT and SCA trainer, as well as being a previous RCGP course director. So I've been teaching for the MRCGP for coming up to over 20 years, and I want to share some of that experience with you because I'm aware that some of you tonight will be attending because you're resitting, and some of you will be taking it for the very first time. So I suppose when we start thinking about the AKT, it's very important we start thinking about strategy. A few ground rules as we move forwards. I've just muted your audios and videos just so that we can minimize any static. Do use the chat function to ask or answer any questions. It's going to be very, very interactive tonight. There's no recording, unfortunately, of the webinar. I'm trying to record it from my side, so hopefully it will be online if the recording is successful. But feel free to take any snapshots of the slides as we move forward. So no one likes taking the exam. Of course, the AKT is a bit of a nightmare, in addition to all the other kind of loopholes that you have to jump through. But ultimately, it is a tough exam. Yes, the facts speak for themselves. We do know that the AKT pass rate hasn't really surfaced above 70% for some time. So actually, it's a pass rate that's a lot worse compared to the previous CSA, RCA, and obviously we're yet to see the SCA. But ultimately, when you're taking an exam, and no doubt no one likes taking exams, yes, you may feel, I suppose, a little bit down in the face, a bit like my eldest daughter here. So no doubt when you're preparing for this or resitting for it, you may feel and even look like this. But actually, what we're hoping to do tonight after this strategic webinar is get that energy back into you. And just be aware that there is a method to the madness. And we're going to start talking, I suppose, about strategy. So the afterthought really is that we really want to keep you guys positive, because ultimately we want to make sure that you smash this in the new year and don't get too worried over the festive period. But there is a strategy to it. So we're going to start talking about that. And ultimately, hopefully, you'll be smiling by the end of this, because you'll recognize actually there is a way through this that can make it very palatable. And actually, it's not necessarily as onerous as you think it to be. So strategy is key. And there are a couple of sentinel rules that I just want to start off with. If there's any two take-home messages you have to take home from tonight, the first is there is a huge difference between working smart versus working hard. If you've taken this exam several times, I know several of you have, and you're just going for commercial banks, I'm afraid there's no strategy in that. It is a college exam. This is the second rule. It is a college exam which follows college rules. And take this from me as an RCGP ex-course director. Ultimately, we want the college answer, and there are resources that you need to use before you pay for any bank or any course, including mine. Okay, but if at the end of this you find that the strategy works for you, we may see some of you certainly on the Mentor AKT masterclass. Now we're going to do something that I teach on the course called a cover test. Now the cover test is a technique I teach to make sure that actually information that's given to you, you don't just have a AKT knee-jerk or sort of OSCE reflex response. So we're going to look at this picture for 15 seconds, and I would like you to consider, okay, the year in which this photo was taken. Now, don't type anything into the chat group at this point in time, because the options are going to come up in a second. So don't type anything in. Just absorb the question for what it is, okay? 10 seconds, and then the options are going to come up, and then we're going to see basically in the chat group who gets the right option. And I would like everyone to participate in this tonight. Okay, as I said, Sanitha, don't type anything into the chat group. Okay, so the first lesson of the AKT is please listen to the instructions. So your options are coming up now, and you have 20 seconds to type in the correct option, please. Everyone should be typing something into the chat group now. Thank you. Well done, everybody. Let's have a look-see. So this is very interesting. Lots of people going for GP. Lots of people saying actually it's not that at all. Some people going for hospital. Let's see who's got this actually correct, because actually we don't have too many correct answers in here. And let's just see who's actually got it right and why. So breaking down the AKT is not about having a knee-jerk response. Now, if you actually absorb the information of what I was saying right at the start, and specifically, you know, if you're focusing, I suppose, on what I said before we launched into this, you know, in terms of actually data extraction, what we see here, firstly, is an old computer, a light box. Now, did we ever have light boxes in GP practices? And the answer to that is no, we did not. So it cannot be in a GP practice. So I've already narrowed it down now to hospital. Okay, so I've got B, D, F, and H. So if we are now looking at a group of junior doctors, specifically if I absorb the photo, you'll observe the men in that photo, a younger version of myself and my colleagues, were wearing ties, watches, were not bare below elbow. So this cannot have been taken this century. It must have been taken last century. So now I narrow it down to F and H. And I suppose at this point, it just depends on how kind you want to be to me. So if I was a junior doctor in 1990, which, you know, was really some time ago, in fact, if we calculate that out, then that was basically, you know, 33 odd years ago. Okay, and if I was a junior doctor at 24, that would make me 57 years old right now in front of you. Now, obviously, you're being very kind or very harsh because I'm not quite 57 yet. Hopefully not. Okay, I'm getting there, but not quite. So who's got this correct? So Harshal got this correct. Well done. So it's F is the answer we're looking for. Who else got F? Not too many of you, to be fair. Okay, but if you did get it, well done. So the key really is not having a knee-jerk response. It's about actually really dissecting the question apart, and we're going to be doing another cover test very shortly. Julia got that right also, so well done, as well as Zain and Mosan. Okay, so yes, I've been around for some time, but there is a reason for that, because, you know, I've worked for a long time teaching the MRCGP through the old days to the new days, and I know how this exam is constructed. It's very important, though, as we evolve, to recognize that doing an online paper is very, very different from doing one that's a hard copy in front of you. So much information coming at you, and very important not just to have a knee-jerk response. So the cover test is really important, and the way that I teach to learn for the AKT is very much around patience rather than factual recall. So a lot of people, I suppose, when they run webinars, and I've seen many run by other commercial course organizers, will simply just go through questions. That's not how we're going to do it tonight. We're going to talk about complete strategy in how to dissect your preparation, most importantly. And it starts very much with making sure that you don't overload yourself. You do not have time to invest in lots of commercial banks. If you've taken the exam before and you're just going back to another commercial bank, it's not going to work. Okay, there is a difference between quality and quantity of revision. So working smart is very, very important. You can't cram for it, but actually if you do a little bit every day from here on in, you still have enough time. Question recognition is not simply enough. Okay, it is called an applied knowledge test because you are applying your knowledge and making sure that actually you're just not going for knowledge recall in that sense. So the themes to consider in this: you've got to strategize, you've got to prioritize, and you've got to focus. And tonight we've already touched upon some techniques in problem solving the cover test rather than just having a knee-jerk response. And we're going to talk about these themes as we move forward. So some of you are taking it for the first time. I know we've got some ST1s here tonight, so you're very welcome. You can only obviously sit it from an ST2 onwards. There's a maximum of 4 attempts with a possible mitigating 5th, depending on where you are. And it's very important you have a look at the Pearson VUE tutorial before you attempt this. Make sure that you use the scratch pad. And at this point, I would like all of you to get a piece of paper out because you're going to use it. Tonight's going to be really interactive. We've got competitions, we've got polls. You're not going to sit there passively, despite there being so many of you here this evening. We are going to make sure that actually all of you refine your strategy by close of this webinar. Time management's key, so it's less than a minute per item, and you have an online calculator, which you will need for the stats busting. So the questions will range in the following formats, but typically they like using SBAs, EMQs, and MBAs, and then there's some free text stuff as well. There's a strong emphasis on clinical problem solving. And when we start looking at the topics, medicine 80%, admin 10%, research and stats 10%, weakest areas tending to be around the kind of hot topics and recent evidence-based medicine, in addition to the statistics. Now, the thing with stats is that stats never changes, actually, because risk never changes. And I'm going to demonstrate that tonight again with strategic technique. So a few snapshots from the Pearson VUE tutorial. It's relatively straightforward. You have a timer on the right top side. You can mark questions and flag them for review. So at the end, you can see what you've not answered. There is no negative marking. And I suppose the issue is if you hit stats about an hour in, you're already going to be very tired. So we need to use that scratch pad strategically from the start as soon as you're allowed to write. And again, this is all about technique. All right, so time management's everything. We've already seen the cover test being very, very important, and extraction of information before you even look at the options. It's about making sure when you do look at the options, you mark the answer box carefully. Skip the difficult ones out, but really do try and hit the stats when you're fresh. Make sure you make an educated guess for everything, because again, no negative marking, and keep an eye on the clock. So when we start thinking about, I suppose, your results, everything's going to get sent back to your 14 fish, and some of you have already sent me your results. And again, it shows themes of statistics not being particularly well performed, not hitting over 70% in clinical medicine. You really need to hit over 70% consistently in clinical medicine. And in terms of the stats, you really need to be getting about at least 16 marks out of the 20 items in order to get a good shot at this. All right, we're going to run a poll. Again, this is about working smart. You won't need to put anything into the chat group, so please listen to the poll. I will launch it in a second. With regards to the AKT, which national guidance does the RCGP tend to favour? The poll is coming up in a second, so don't answer anything at this point. Just wait for the poll. It's launching now, and you have 30 seconds to answer it. We want to get about 90% of people answering, just to get a flavor tonight of how you're approaching this. I've got 83% so far. Let's get a few more people answering this, please. You've got to be in it to win it. 87%. Let's get it up a little bit higher, please. Okay, so we are going to end the poll at this point in time, and let me just share the results with you. So the majority of you have all gone for A, which is NICE guidance. And then in second place, we've got NICE for the assessment of a disease or its diagnosis, and SIGN for its treatment. And then we've got SIGN for the assessment, NICE for the treatment, and then lastly SIGN. So let's talk a little bit about this, because ultimately this isn't actually an exam that solely depends on NICE guidance. The answer actually is C. And why is that? Well, strategically, the exam covers Scotland, and there is no NICE guidance in Scotland because NICE equates to QOF, and there's no QOF in Scotland. So actually, in Scotland, NICE guidance was abolished about 6-7 years ago in the context of QOF and how it related to QOF. And that's very important, because when you actually look at the college resources, they absolutely specify you need to know both guidances. And I'm going to showcase this again tonight. So if you're someone who's been using a commercial bank that solely relied on NICE guidance, you're already shooting in the dark. There's no strategy in that. You have to go back to the source. So what is the source? The source is the AKT summary reports. The AKT summary reports are published after every AKT sitting. We are awaiting the October AKT summary report, and you need to look at the themes that have originated over the last at least 2 years, ideally 2.5 years, so you can map them to the college resources, which include the essential knowledge updates and the associated challenges. The challenges are free questions, and so are the essential knowledge updates. They're free to use for you as an AIT. you need to look at the appropriate e-learning modules, but most importantly, you must have done the GP self-test at least twice, ideally 3 times, and scored consistently around 75% before you attempt this exam. If you have not done that and you're just going for commercial banks, I'm really sorry to say, but there is a very fair chance you will fail this exam. It is a college exam and it follows college rules. So when we start looking at the themes, and we're going to go back over the last 3 years, we're going to do some of these themes tonight. Have a look. Okay, we've got end of life, medicines management comes up a lot, health and safety in the workplace, statistics, the difference between absolute and relative risk, antibiotic use, fundal images, respiratory disease. We are moving forwards again now to January 2021, neurological symptoms, safeguarding, capacity and consent, confidentiality. Now, if we start moving forwards again, okay, GMC transgender issues, end of life prescribing, dermatology images, oral contraception, insulin regimes and diabetes, neurological presentations. So we already seen that. Okay, asthma coming up again, safe prescribing. I saw that 2 sittings ago. End of life decisions I saw again. Drug dose calculations, immunizations. You don't have to learn the full schedule. If you looked at the AKT summary report, they specifically talked about specific groups of individuals, so teenagers, for example, and Gardasil, or specifically contraindications when it comes to live vaccines. Again, safe prescribing, access to patient records, ECGs, I've already seen that before, GI long-term conditions. And now as we start moving over the last year, GMC again, confidentiality issue, ECGs again, long-term conditions again, contraception, medicines management, prescribing in children. We saw that before, antibiotics, asthma. I've seen asthma 3 times now, contraception, eyelid conditions. And then in the spring sitting, antibiotic prescribing. We've seen that 3 times, drug monitoring, notification of death requirements. Why is that important? Because it differs between England and Scotland. Okay, the Scotland death certification is very different from that which exists in England. Use of social media, possible emergency presentations. So when you have a look at the AKT summary report, if I was limited for time, I would go for the high yield areas as been highlighted from the AKT summary reports over the last 5 years. And we're going to touch on some of these this evening. That strategy. Okay, please don't shoot in the dark because you will miss. It's very important. Again, you work smart and not hard. So why is this important? Because actually it's already highlighted by the RCGP. If we have a look at one of their old AKT statements, it specifically said we've reproduced our statement because it's very likely that similar items will appear in subsequent tests. In other words, if you're taking it in January, the most important thing is to get hold of that October AKT summary report when it is published in the next couple of weeks. That will highlight what is going to be coming up again. And when it comes to guidance, again, the reason why NICE does not trump anything is because it's already been stipulated by the RCGP. So the 2 guidances are taken into account when writing, updating, selecting our questions. Candidates need to be aware of the areas of consensus and the areas of discrepancy between major guidelines. The biggest discrepancy being between NICE guidance for asthma and SIGN guidance for asthma. In fact, there is going to be a collaboration between NICE and SIGN over the next couple of years to jointly produce asthma guidance that basically correlates with each other. But right now, you need to know both. Now, actually, if you dissect some of these EKUs and modules, it is absolutely clear that the RCGP favors SIGN for particular areas. Again, I will showcase this to you this evening. If we have a look now at osteoporosis and the EKU summary reports from 2015, updated in 2021, you can see already this evidence update differs from the existing NICE clinical guidelines, which purely focused on assessment. SIGN made treatment recommendations, and specifically they say in the RCGP we will be using Q fracture rather than FRAX and setting a 10% fracture risk. Now that is really central information to know before you start spending hours trying to learn osteoporosis NICE guidance, which never features in this exam. And actually, if you have a look at specifically the osteoporosis guidelines and the E module, that's really highlighted with the RCGP. In other words, the golden rule is don't touch NICE guidance for osteoporosis because it doesn't feature, and that saves a lot of time. Candidates need to look at the essential knowledge updates, and you need to be looking at those for the last 3 years along with their challenges. So there's plenty of stuff that you can do, and this is highlighted by some recent testimonials that were sent to me very kindly by people that came through the Mentor AKT masterclass, candidates who'd failed the exam before, college exam, college rules. So moving forwards, we need to focus on those hot topics that come up through the examination summary reports. We need to map this to the curriculum, and specifically we need to be absolutely key when we're looking between NICE and SIGN. Now, clinical knowledge summaries, although it aligns to NICE, actually does highlight SIGN guidance. If you have a look, for example, at migraine, it talks quite a lot about the sentinel differences between NICE and SIGN in terms of, for example, prophylaxis. So if you look at, for example, at SIGN guidance for migraine, it talks about the use of ARBs that doesn't really sort of feature in NICE, and NICE talks about riboflavin and acupuncture, which doesn't feature in SIGN. So again, you do need to know both. Be aware of those recent hot topics. And again, some of these images that come up, fundoscopy, you've seen quite a lot. If we have time tonight, we will do a quick image slideshow around fundoscopy. Timing, as we've said, is absolutely key. So let's talk a little bit, I suppose, about how the hot topics are based. They're based on common low impact problems, rare high impact, specifically about managing risk, topical areas, which we've already talked about. And again, just highlighting the sentinel differences between some of these guidances. Now, we make that work quite easy for you on the Mentor AKT masterclass, because otherwise it takes a lot of time researching both guidances and going through the EKU summary reports. We do all of that for you on the one-day course and really highlight which guidance to follow for which area. What lends itself easily to AKT questions, and specifically those common conditions in primary care. When it comes to the actual questions themselves, then you're going to be examined on etiology, disease factors, symptomatology, investigation, and how you might go about managing it. And that also includes management potentially in secondary care for common problems such as stroke. We've seen that now with the EKU update that came out for stroke about a month ago. We'll go through a question around that in a tick. Okay, should we do a cover test? So neurological presentations, okay, which 3 of the following presentations warrant urgent review? Before we even look at the options, I want you in the chat group to think about specifically conditions and diagnoses that might require an urgent review. And NICE defines an urgent review as within at least 2 weeks. So what sorts of diagnoses might need to be seen within a 2-week period or earlier? In the chat group, you have 30 seconds to put your thoughts down, please. So GBS, cauda equina, stroke, so vascular issues. Yep, sure. What else? Seizures, I like that. Epilepsy, thank you. So we've had TIA, space occupying lesion. Thanks, Amina. That's good. What else? Okay, so cauda equina syndrome, transient ischemic attacks, stroke, epilepsy. Anything else? Anything else for anything else? Suspected MS? Yep, possibly. Okay, so we've got a group, subarachnoid hemorrhage, so I like vascular. Vascular's good. Okay. So infectious issues. Okay, so we've got a kind of list that we've got in our head. And now what we need to do is map that to the symptomatology. So I'm hearing vascular, I'm hearing space occupying lesion, I'm hearing epilepsy, I'm hearing demyelination disease. Okay, so other things I suppose that would kind of encompass that. So for example, Huntington's chorea, motor neuron disease, but these are all things obviously that are going to present with certain types of features. Let's run a poll. Again, you don't have to answer anything right now. I'm just going to show you the responses. Okay, and I'm going to run a poll, and you're going to have a couple of minutes to do this so that we can have a look-see. So let me just set the poll up now. Okay, so neurological presentations. The poll is launching. You need to answer, please. Okay, get them in, get them in, get them in. We want to get it up to about 90%, please, people, 90%. Keep going, keep going, keep going. You're doing well. Keep going now. Keep up the energy. Come on. We're at 60%. Come on, let's keep going now. I want it 90%, please. 90% of participants. You have to do this because you're going to have to do this in the exam. You need to be in it to win it. Don't be passive, be active, please. It's all anonymous anyway. We just want to see what the group thinks. We're up to 85%. Come on, let's get it over 90 if we can. Come on, keep going. 87, 89%. Come on. Keep going, keep going, keep going. Fantastic. 91%. Well done, guys. Okay, I'm going to end the poll. I'm going to share the results. So, in top position, we had rapidly progressive ataxia. And yeah, that sounds sensible, doesn't it? I start thinking about potentially cerebellar lesions. They could be space-occupying lesions or vascular lesions. Or specifically, we could start thinking, about things like multiple sclerosis. So yeah, I will give us that. What came in next? We had E, blackout not due to vasovagal attack. Yes, anyone who's had an acute blackout, we need to start thinking specifically, have they had some kind of vascular type event? So I agree with that. And then what came in next? We had D, repeated transient smell and taste hallucinations. Absolutely, we need to start thinking about epilepsy and partial complex seizures. What came in after that? Well, we had actually, no, even before that, we had scalp tenderness with jaw claudication. So I apologize. We had in third position, H actually. So H came above seizures, scalp tenderness with jaw claudication. That's very interesting. So you're all thinking about GCA, but actually, again, when you read CKS guidance for GCA, that does not require urgent review. What requires urgent review is if you've actually got eye complications with that. So remember, when we start thinking, I suppose, about GCA, there is a spectrum. We've got polymyalgia, we then have polymyalgia with giant cell arteritis, and then we have specifically eye complications and potential amaurosis fugax. So if you have eye complications, it requires an urgent review, but specifically if it's scalp tenderness with jaw claudication, you really need to be actually handling that, and that does not necessarily require that to be seen within 2 weeks. Okay, you're going to be starting steroids and having a discussion with a rheumatologist. Other things that came in, so gait apraxia. Well, no, not really, because actually, if you're a bit, under the influence of alcohol, you're going to be pretty gait apraxic. Loss of smell sense more than 3 months. Well, long-term COVID, does that require urgent review? Not necessarily. And then lower down the list, we had facial allodynia and Bell's palsy. So when we start thinking, I suppose, about where we're going with this, let me just make sure, actually, hold on 1 second. I'm just going to stop the share, just want to tick and close that down. So I just need to let someone into the room there. So the answers here are A, D, and E. Now, how would you go about finding the college answer to this? Well, specifically, there is an EKU module that was mapped to NICE guidance. Other additional presenting features would include rapidly progressive limb weakness, recurrent brief pattern alter sensation, persistent limb alter sensation, and brisk reflexes. Again, all kind of vascular stuff, all kind of encompassing stuff like demyelination, autoimmune disease, motor neuron disease. So this is the way to do it. You go to the RCGP learning website, the e-learning website. We've already seen neurological presentations as featured at least 2 to 3 times over the last 2 years. And you can see from the AKT summary report, it's a highly, highly topical area. So I type in neurological into the e-learning website and bingo, I've got suspected neurological conditions, how to recognize and to refer. So I've got the college answer. That's what I want, the college answer. That's strategy, isn't it? And we teach you this quickly on the masterclass. Actually, I know some of you are coming on masterclass this Saturday, so I really look forward to working with you on this. But we do quick fire rounds, teach you how to remember the EKU quickly. So stuff that can be contained. So that was about risk escalation. If we thought about neurological conditions that need to be managed in primary care, it's the following list. And specifically, they put scalp tenderness with jaw claudication. Now, the argument could be, well, actually, if I've got someone with, GCA without eye complications, ideally, they should see a rheumatologist sooner rather than later. We're thinking maybe about a temporal artery biopsy. But guess what? I want the college answer, and this is the college answer. So benign positional vertigo, Bell's palsy, any sort of radiculopathy, insomnia, sleep paralysis, tics, tremor, hypnagogic jerks. So very important college exam, college answer. Okay, more recently, we've had an update on stroke. So some snapshots from the e-learning website. Should we do another quick question again? No need to put anything in the chat group at this point. We're just going to do a poll. Here's the question. So acute stroke treatment. Let me launch the poll again. Give me 1 second while I do that. And you'll have about a minute to answer this. So I'm just launching the poll right now. Give me 1 tick. Here we go. All right. Whenever you're ready, let's get over 90% of people participating, please. Keep going, guys. Doing really well. Got 36% now, coming up to 50. Well done. Keep going. Remember, it's timed. Come on, let's get up to 90. Let's get up to 90. Come on, let's get the energy up. Come on. Just another 10% of you to answer. Come on, let's do this. Let's just hope this question comes up in the AKT. Come on, keep going. Almost there. Over 90. Come on. Couple more people answer. Come on. Yes, yes. All right, I'm going to stop the poll there. Shall we share the response? So overwhelmingly, most of you went, 49% of you, for antihypertensive treatment if the BP is 16/42. And then in second place, we had high intensity statin treatment. And then in third, tight blood glucose control. Okay, so let's just go back and stop that for the moment. Let's have a look at what the college answer was. The answer was high intensity statin treatment. So again, these EKUs are actually very, very useful because they summarize a lot of this kind of secondary care very quickly for you. Supplemental oxygen only given if O2 stats are below 95%. Blood glucose control should be between 5 to 15, so tight blood glucose control not necessary, which is very different if they'd had an MI. We need to know the thresholds for treatment. Again, we go over this on the masterclass. So we're only going to really treat if blood pressure is above 185 over 110. So high intensity statin treatment is the answer. And again, don't be disheartened if you got the answer wrong. The whole point of tonight is to strategize. This is what I mean. It's about strategy. It's not about shooting in the dark. It's about making sure you go back to the college. Okay, we're going to touch now stats and all that. And what I'd like you to do is I'd like you all, please, if you possibly can, some of you may be on the move, but if you are stationary and safe, can you get out a blank piece of paper? Because we're going to have a really exciting competition, and there'll be a prize, by the way, with this competition. So it's in your interest to get out a piece of blank paper and a pen, which is going to mimic your scratch pad. So what do we need to know? What we need to know is there's 20 questions, and people always come out and go, oh, there's so much statistics. It's only 20 questions, but the issue is it slows you down because you have to either number crunch or interpret a graph, and every single graph, every single plot relates to the extraction of risk. So we go over this on the AKT masterclass, but more importantly, more recently, I've developed an AKT modular stats online course, which really breaks it down for you very, very simply. And you can subscribe to it for 45 days. And I'm kind of there as a virtual tutor, talking you through all the plots and graphs, but most importantly, taking you back down to the basics of risk. And you've seen that already feature in the AKT summary reports, that actually a lot of people fail this because they don't understand the sentinel differences between absolute and relative risk. And we're going to break that down for you tonight. But other things, obviously, that you need to be aware of: numbers needed to treat, sensitivity, specificity, positive predictive values, odds ratios, confidence intervals, all the studies, and then all those plots. But you can't really look at a plot until you've broken down the sort of basic pillars of risk. And by the end of this webinar, you should be able to look at something like this and go, I'm not fazed by this. Okay, and we're going to cover this now. I've got some free YouTube resources that goes over Kate's plots also, but let's give this one a go. There's going to be a bit of a competition. Now, you've got your scratch pad. What I'd really like you to do is start writing down these equations. Okay, now what's risk? Risk is the probability that something bad is going to happen. Okay, and we can only work out risk if we are moving forward. So it's a prospective measure. All right, and when we talk about risk, we can give it as a percentage or as a decimal form. So it's very important you look at the answer. If the answer is 10%, then it's either 10% or it's 0.1, but it is not 10. Absolute risk is also known as attributable risk. It is the risk that's attributed to the individual. So it's the number of bad things happening over the total number of people. So if I wanted to look at the number of people that failed the AKT, perhaps in the group that was attending tonight, and hopefully it's not going to be you guys, but I would take, you know, the number of people who failed over the total number of people who are attending this webinar. So absolute risk is the same as attributable risk. Now, our aim is to reduce that risk by applying a treatment. If we apply that treatment, we've now got two groups: an absolute risk in a control group, which is also known as the control event rate, minus the absolute risk in the treatment group, which is also known as the experimental event rate. But sometimes treatments actually don't reduce risk, they can increase it, in which case we're no longer doing an ARR, we're doing an ARI, which is the ART minus the ARC. Relative risk is interchangeable with risk ratio. It is a comparison between two groups or two populations. And that's very important because ratios, by default, if the ratio is 1, there's no difference between the groups. Now, if I was looking at the relative risk of an event in a treatment group, I would take the absolute risk in that treatment group and divide it by the ARC. So right now, you guys should be writing these things down. You should be writing down on your scratch pad, ARR equals ARC minus ART, ARI equals ART minus ARC, relative risk equals ART divided by ARC. Now with a ratio, okay, the starting point is always 1, because if the ratio is 1, there's no difference between the groups. 1 is also 100%. So if our starting point with relative risk is 1, then our relative risk reduction is 1 minus the relative risk. Again, a very important equation to write down. Excuse me, I've got a frog in my throat. Numbers needed to treat. The number of people we need to treat to prevent one bad thing from happening. It is the reciprocal of the ARR. So if your ARR is given in decimal form, it's 1 divided by that. If it's in a percentage, it's 100 divided by that. Excuse me. If your treatment, though, has caused harm, we are now dealing with a number needed to harm rather than number needed to treat, which is the reciprocal of your ARI. Let me just clear this frog in my throat. Odds ratio. Odds ratios can be defined in 2 ways. Firstly, prospectively, if you're moving forwards, or rather retrospectively, if the bad thing has already happened and you want to look at exposure to risk factors in the past, that's when we use an odds ratio, okay? So remember, you can only truly work out risk if you're moving forwards. If the bad thing's already happened and you want to look at exposure to risk factors retrospectively, that's when we use an odds ratio. If we use an odds ratio prospectively, it's the odds of an event happening in a treatment group expressed of it happening in a control group. Again, we go into a lot of detail in this on the masterclass and obviously with the AKT Stats modular course. We won't cover it tonight, we don't have time, but the most important thing is to remember when you're dealing with a ratio, the starting point is always 1 or 100%. If the relative risk or odds ratio is 1, there's no difference between the treatment and the control groups. But I do want to talk you through the sentinel columns of risk tonight. And again, we're going to have a little bit of a poll and a competition. All right, here we go. So consider the following data from the 4S trial of cholesterol reduction in patients with ischemic heart disease. And we're going to run a poll. So again, nothing in the chat group right now. Okay, I'm going to give you guys about 2 minutes to do this in a second. In the placebo group, 12% of patients died. In the Simva group, 8% of patients died, which was a risk reduction of about 30%. Okay, which single answer correctly describes the data? Nothing in the chat group. Poll's going to be launched now, and you've got 2 minutes, okay, to give this a shot. So here we go. I'm going to launch it. Oops. 1 second, sorry. I don't know if you can see this at all. Doesn't look like it actually. Hold on 1 second. Let me just try that one more time, guys. Hold on 1 sec. I'm just trying to launch it right now. Hold on 1 sec. Oh, it doesn't look like it's working. Okay, we're going to revert to the chat group then. So, give you 2 minutes, and if you're able to put the answer in the next 2 minutes, that would be fantastic. Give it a go. Okay, thanks Aditi for putting yourself out there. Thanks Zainab too. Let's keep going, guys. Thank you so much for putting yourselves out there. Really appreciate it. Keep going, keep going, keep going. Keep going. Let's see what we've got, guys. Thank you, guys. Thank you. Apologies that the poll has stopped for some bizarre reason, but I'm really glad you guys are putting yourselves out there this evening. Lovely, lovely. I've got about 50% between C's and D's. Any more for anyone? Any more for any more before I call it? But thank you so much for contributing. Okay, I'm going to call it, and it's literally about a split, 50% C's and D's. So the answer is D. Okay. Okay. So don't worry if you got it wrong. Thank you so much for trying. Let's think about what's going to happen when we get into the AKT. So we've done the AKT tutorial. We've got our scratch pad, and as soon as we're allowed to write, all our equations should be going down a bit like this. Okay, so our ARR is our ARC minus our ART. Our relative risk is our ART divided by our ARC. Our relative risk reduction is 100% minus that. Our numbers needed to treat is the reciprocal of our ARR. So now we come across this question, and we know what the bad thing is happening. Okay, so in the placebo group, 12% of patients died. In the Simva group, 8% of patients died, which was a risk reduction of about 30%. So the question here is, what is that risk reduction? Is it an absolute risk reduction, or is it a relative risk reduction? So our ARR, okay, is our ARC, which is 12%, minus, okay, our ART, which is 4%. Our relative risk is our ART divided by our ARC, 66%. So our relative risk reduction is about 30%. So that's what we're being presented with. So a relative risk reduction, remember, is not an attributable risk to the individual. It's a comparison between two groups. So when an individual comes to see you and they go, oh, wow, like, you know, this drug is amazing, you know, it's going to reduce my risk of death by 30%. It's like, it's not, because that's a relative risk reduction. Our job and our challenge as doctors is to make sure these patients that we're seeing who perceive this risk actually understand what it means for them. In other words, what is the absolute or attributable risk? And one way of presenting that is through a numbers needed to treat, which is the reciprocal of our ARR. So I need to treat at least 25 people for one person to benefit. 24 aren't going to benefit at all. And that is really important when you're looking at graphs and plots. You need to be thinking to yourself, am I actually looking at absolute risk, or am I looking at relative risk as an outcome measure? So now I'm going to teach you how to break down a Kate's plot. Again, you know, this is on my YouTube channel, so I go into this in more depth. It's a free resource. Do please subscribe to the YouTube channel and have a look at it. So a Kate's plot, basically, when we look at a Kate's plot, all we're interested in terms of risk is the red and yellow faces. Let me take you through this, okay? Nothing happens to the green faces, so we're only interested in risk, the red and the yellow. Have you got your piece of paper at hand? Because you'll be needing to write on it again, okay? And this is how I teach technique strategically when it comes to statistics, because if you've got all your equations there, you won't need to worry. Let's talk through a Kate's plot first. Kate's plot's always based on 100 people, so it's easier to work in percentages, is the first thing to say. I'm going to look at a population of 100 people, and I'm going to set the background risk of cardiovascular event at 20%. That is to say, if I don't do anything, 20 people are going to run into a cardiovascular problem in 10 years. My aim is I'm going to try and reduce that risk by applying a statin. Now, if I apply a statin, despite doing that, 15 people are still going to have a cardiovascular event, which is encompassed by the red faces. First thing to write down on a Kate's plot, your ART equals the number of red faces. I repeat, your ART equals the number of red faces. Okay, have you written that down on your piece of paper? Make sure you've done that. I'm going to save about 5 people, which is encompassed by the number of yellow faces. Your ARR, the absolute risk reduction, is the number of yellow faces. Okay, I repeat, your ARR is the number of yellow faces. Nothing happens to the green at all. Now, after tonight, you should be able to go onto Chris Cates' website using the equations I'm about to teach you in a second, and you should be able to break down any Kate's plot. That's a free website, by the way, by Chris Cates, nntonline.net, because they love Kate's plots in the AKT. All right, so the equations I would like you to write down. ART, as I said, number of red faces. ARR, number of yellow faces. And if you remember from what you wrote down originally about your risk equations, we can now calculate the ARC, which is red plus yellow. Okay, so ARC is red plus yellow faces. I can also calculate the numbers needed to treat, because that's the reciprocal of my ARR. We work in percentages, so it's 100 divided by the number of yellow faces. Okay, competition time, competition time. Woo, exciting. So I'm going to be giving you a question, and the first person to give me the correct answer will have complimentary access to one of my online resources, the Mentor AKT plots. That's usually £20. First person who gets the right answer. All right. And we're going to give you 3 minutes to do this. Here we go. Calculate the following: the relative risk of having a cardiovascular event in patients on a statin compared to without. Let's see who potentially might get that. Three minutes. 3 minutes starts from now. Anybody else? For anybody else? Remember, your answer has to be in a percentage or as a decimal. Well done, guys. I'm really impressed that you're giving it all a go. Well done. Really good. Really good. And actually, we're all winners here, aren't we, at the end of the day? But we have to have one winner, don't we? We have to have one winner. So the answer, dun, 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 is 75%. Who came in first? Let's have a look. Khaled, well done. Email me after tonight. I'll give you that anyway. Although you didn't give it to me as a percentage or a decimal form, you did get the correct answer. So correct. Email me for your code later on. Let's talk about how we got to this point. we've got our equations down. Okay, so for those of you who didn't get it right, don't worry. Again, this is all about strategy. Practice makes perfect, especially with stats. So what is the control event rate? Red plus yellow. So I've got 20%. Okay. What is the experimental event rate? Number of red faces, which is 15%. My absolute risk is 5%. Okay. My numbers needed to treat, 100 divided by 5. So my relative risk is going to be my ART divided by my ARC, 75%. So actually, just by giving you this Kate's plot, I can get at least 5 questions out of you. And that's why it's so important that we understand the sentinel differences between absolute and relative risk. Okay. So again, I go over this on YouTube. I've got a nice little Kate's plot, 10-minute webinar. So if it hasn't quite clicked home, that's okay. Don't worry. We just revisit it. It's there. It's free. Do give it a go again. And if you do want to kind of get stronger at stats, if stats are something that's let you down or you're a bit weak in it, we are doing of course, Black Friday special offer. It's only valid for 24 hours till midnight tomorrow night. This is usually £95 for 45 days access to 3 modules where we go over everything, risk, odd ratios, everything that I've just talked about, and all the plots and graphs. We're reducing that now to £70 for 45 days access. I'll be sending you an email of how to sign up if you're interested. I'll put some links towards the end. Okay. It's really important because stats never changes. And actually, again, we've got, some really nice testimonials of people who've absolutely smashed this just on the stats alone when other areas have potentially let them down a little bit. So please don't neglect this. You need to be scoring well on this because stats never changes, because the interpretation of risk never changes. So very, very important. We'll teach you how to use your scratch pad. I've taught you a couple of things tonight. So specifically how to write down your risk equations and Kate's plots, but we'll talk about screening and odds ratios on the masterclass and also on the modular course. But once you're sorted like that, there shouldn't be anything that really phases you. Okay, shall we move on to something a bit more admin-y and organizationally? All right. I don't know if this is going to work on my poll. Let me just see one more time. I'm going to try one more time. Hold on 1 second. If it doesn't work, it doesn't work. Don't know what's happened to my poll. Okay, don't worry. Let's use the chat group then. So which one of the following conditions qualifies for prescription exemption in the chat group? You guys have been really proactive tonight, so let's just keep up the energy. What do we reckon? Got about 30 seconds, guys. It's a single best. What do we reckon? Which one of the following conditions qualifies for prescription exemption? Okay, answers all coming in. Thank you so much. Pretty much unanimously, it's D. Well done. Well done. Okay, so the easy way to answer this strategically is anything that's underactive allows you to have prescription exemptions. So I've got rheumatoid, there's just too much autoimmunity going on there. Same with Graves, too much steroid in Cushing's. In Addison's, no steroid. Hyperparathyroidism, prostate cancer, no active treatment. So again, just important to make sure that these admin aspects, which never change really, actually, you get au fait with. So NHS prescription exemption, there's the list, and this is factual recall. There's no application per se. Okay, so let's move on to something which is a bit more interesting, because as you've seen, there's been quite a lot of stuff on child governance, confidentiality, safeguarding. So parental responsibility has been an interesting hot topic. I've got the father of a 3-year-old girl who rings the GP and dissents to the routine preschool immunization of his daughter. He's now divorced from a mum who's consented to the immunization. Both parents have their name on the child's birth certificate. So in the chat group, firstly, who has parental responsibility? Is it the mum, the dad, or is it both? Let's see what your thoughts are in the chat group. So I'm really liking the interaction, guys. Thank you so much. This is really bringing it to life tonight. I really enjoy this. So okay, so far it's quite an even split actually. So I've got about half saying it's the mum, half saying both. Let's just get a few more responses. What do we reckon? Is it mum? Is it both? Both. So it looks like actually the majority have gone for both. Okay, so we'll have a look at the answers now, and I want you in the chat group to choose the most appropriate action, if that's okay. Thank you. So in the chat group, do put down your answer. What do we reckon? What do we reckon? So lots of people going for C, administer it. Some people going for A because they've talked about mum having parental responsibility. Let's see, who else? Who else? Give it a couple more minutes. So it's a real toss up here between A's and C's, and I've got a splattering of E's, but mostly A's and C's. Another minute, or rather 30 seconds. Okay, I'm going to call it there, guys. Again, thank you so much tonight for your participation. Really appreciate it. You have to be in it to win it. Here we go. So the answer's E, because both have parental responsibility. Okay, so it's very interesting because this actually went to a court of law. There's been a few sentinel cases. Ultimately, a court of law has ruled in the mother's favor, in that it's the best interest of the child, but that is not a decision you can make when both parents have parental responsibility. And again, this really is key because it depends on where the child was born. And that's why with the AKT, because it's a national exam, you need to know the national guidance. So a child's mother will usually have a parental responsibility, as well as a father married to the mother at time of the birth of the child. So unmarried fathers will only have automatic parental responsibility. And again, it depends on where the child was born and after when. Northern Ireland, as you can see, England, Wales, Scotland, different dates, and the father's name is on the birth certificate. Parental responsibility can also be held by adoptive parents, those appointed as legal guardians, or those given a residence order. And additionally, when a child is subject to a care order, parental responsibility will be held by the local authority. So again, this admin stuff, it doesn't change. It's just there. It's factual recall. You do need to know it, and we'll give you some tips and tricks to learn that on the course. Most importantly, divorce, marital separation does not affect parental responsibility. Okay, right. It was only meant to be an hour, but actually I do have some images. I'll take a vote here. Who would like to see a quick image slideshow? Images. Okay, well, all the bassies. All right, well, you guys, the energy seems up here. Let's do it. All right, so fundoscopy's come up a lot, so we'll end on this then. But let's do a bit of fundoscopy, shall we? So when we start looking at fundoscopy, specifically, there are only really two areas that you're interested in, which is the macular and the optic disc, because if both these areas are affected, then we have to escalate the problem, basically. And a lot of the AKT is about management of risk. In fact, the SCA is all about that too, and some of you may be attempting that. And I run many courses, as probably you know, for that particular aspect of the exam. But when we look at fundoscopy, don't worry too much necessarily about what's led up to the retinopathy. More importantly, look at the areas that are affected. So when we start thinking about fundal images, you want to be looking at the macula and the optic disc. Anything that essentially affects that is retinopathy. That's it. Okay. Hemorrhages, aneurysms, microaneurysms, which you can get obviously in diabetic retinopathy, because the vasculature becomes weaker. Hard exudates, the proteinaceous exudates, so they can happen in diabetes, and obviously hypertensive retinopathy. So we'll start, I suppose, with what elderly patients might sort of complain on, which is a disturbance in their central vision. And macular degeneration is obviously something that one needs to be aware of now. When was the last time you and I did any effective fundoscopy? The last time I did effective fundoscopy was on a PACES exam when I was a medical registrar. So, we don't dilate pupils very well. But for the AKT, suddenly you've got amazing fundal images. So we've got some amazing fundal images here tonight. So firstly, we've got, dry macular degeneration. So lots of drusen, which are kind of, again, proteinaceous type deposits. But the more serious form is wet and inflammatory macular degeneration, where you can get retinal detachment. The issue, again, is very much around a disturbance in central vision. Okay, so diabetic retinopathy, as we can have a look here, the macula is relatively spared. Okay, the optic disc, I don't have any new blood vessels. I mean, it's pretty horrible. I've got, some dots and blots hemorrhages. I've got obviously these hard exudates. I've got these cotton wool spots. So these are areas of retinal ischemia, and then these generate, vascular cytokines, and then you're going to get abnormal blood vessels. And it's the abnormal blood vessels, when they proliferate, which are very labile, they can bleed, and obviously if they're close to the macula or the optic disc, that's when you're in trouble. But this is still all classified as background retinopathy, okay, because I don't have any new blood vessels. That's the key. It looks horrible, but it's still background, basically. Okay. Now we'll use the chat group for this one. Oh, not quite yet. Sorry. So here we've got new blood vessels at the optic disc. So that's not very good. You can see they're very tortuous. They're very fragile. If they bleed, your vision's going to be compromised very, very quickly. So that's serious. So again, when we start thinking about serious, not serious, we think about the areas that are involved, the macula, the optic disc, and we think about the blood vessels. Okay, so other features that you can see, arterial narrowing, venous dilatation, cotton wool spots, vitreous hemorrhages. And again, if you've got diabetic maculopathy, again, the macula being involved rather than the optic disc. Okay, what do we reckon? Firstly, we have to decide serious or not serious, and then the appropriate action. So we'll use the chat group, as my poll is not working. Apologies again. A 60-year-old man presents with this. What's the most appropriate action? Okay, so answers are coming in. Answers are coming in. Keep them coming. Keep them coming, please. Fab. I like it. So we've got consistency tonight. This is brilliant. Fantastic. So I've got new blood vessels at the optic disc. That's serious. That needs an urgent review. So there you go. Okay, very, very good. All right. Let's give you another one then. This is a textbook one. What do we reckon? Reduced sudden painless loss of vision to a right eye. Bring it. Fantastic. Oh, wow. We have 100% for D's. That's how we're going. Brilliant. Love it. So that pale optic disc, nothing coming in. Again, serious, macula or optic disc being involved, needs to be seen ASAP. So we've run a little bit over time, but I really hope you've enjoyed that kind of quick taster of, I suppose, how I teach, the strategy behind it. We are running our masterclass for January now. Unfortunately, there won't be another course for January. The next course after this will be probably for the spring sitting. But we cover all of this in a lot of detail. So specifically the stats that we've talked about, we make life easy for you in terms of nice versus sign. There's a very extensive pre-course examination paper which we walk through, more admin and organizational, loads of images, and then a very extensive AKT course handout. And you get also access to the Mentor AKT Stats modular course for 30 days. But if you want to apply for the stats course itself, then, as I said, we have got this special offer tonight in terms of the Black Friday offer, which is valid for the next 24 hours. The webinar is not, the course is not recorded. No, it's not recorded. So you need to kind of be there present if you wish to attend it, Sunitha. But look at this guy. I mean, like, you know, he'd failed the AKT 3 times, and he kept coming, you know, kept coming to see me, and he's like, oh, you know, what hot topic should I do? And I was like, don't, you know, your clinical hot topic's about 70%. You're okay. Your stats, though, your stats is weak. You know, you're only scoring about 12, 13 out of 20. So let's get that up. And, you know, the guy absolutely smashed it with 100% in his stats. But I think he took it a bit too far. I don't think his spouse was was too happy drawing all on the windows there. And as I said, the 2-week access booster. Who won it there? I can't remember who won it now. It's been a bit far back, but whoever won that, you need to email me for your access code whenever you wish. I'll check who won that later on. So how many spaces do we have left? We've got 5 spaces left at a Black Friday offer, but that's only available for 24 hours. I'm going to put in the chat group the booking form. If you wish to apply, it has to be a bank transfer, and that obviously includes the access to the stats modular course. All the courses are approved for study leave budget, and as I said, the stats modular course is also on offer at £75 for the next 24 hours, or you can apply for the plots exam booster by itself. I will be sending you out an email in the next 10 minutes. Please check your spam and bulk folders, which will just highlight how to access these offers, but they need to be paid by bank transfer. So if you go through the website, you won't be able to do it. You have to go through the booking form. These are my contact details. Feel free to contact me about any issues you might be having. And if you're preparing for SCA, then I can definitely help you there. Our SCA course dates are in pretty high demand, to be fair. We're pretty much fully booked out now for December, and our January dates are open. You'll need about at least 10 weeks after the course before sitting. We've updated our online bank of mentor SCA consultations, which you can also subscribe to. Well, I think we've covered a fair amount tonight. Do join us on the website and on YouTube. The plots booster, do have a look at the website. It's all on there, and I'll be sending you an email. Okay, so I'm very happy to take a quick Q&A. If you have anything you would like to ask me, then I'm going to hang around for about 5 minutes. Do let me know if you've got any questions at all. When will the April course for AKT be? It's early March. So I usually run my course about 6-7 weeks before each sitting. Anything for admin? Yep, we cover that a lot on the course, but ultimately, again, you've got to look at what the college deems topical. GMC guidance specifically comes up a lot. Obviously, DVLA stuff comes up a lot too, in addition to confidentiality, IT governance. Okay, good. All right, guys. So I've probably kept you over 11 minutes beyond time. Thank you so much for coming this evening, and I wish you a very Merry Christmas, and specifically a Happy New Year and success in 2024. Okay, take care. Bye now. Big love.